Good morning. Greetings from the remote healthcare division of the Apollo Hospital Group, India. Over the last few weeks, we have witnessed that hundreds of videos have been uploaded in the social media dealing with coronavirus. It is unfortunate that not one of them talks about the deployment of telehealth in the management of COVID-19. As you can see in this slide, as of 20 minutes ago, on March 18th, 185,000 cases have been documented worldwide. India at the moment is in stage 2, and I do hope that in the next 1,000 seconds, I will convince every one of you that we would be doing an injustice if we do not use telehealth in the containment of the COVID-19 infection. Now, COVID-19 or the coronavirus has in just a few weeks transformed life on this normally peaceful planet. This exponential disruption is not because of the biology of the virus per se, but mainly because of a consequence of the massive global measures being taken to contain the rapid spread. Global economy is taking a huge hit, and we do not know whether it's going to become worse or not. A webinar conducted a few days ago by the American Hospital Association projected what they called a best guess epidemiology, and it was frightening to note that the American Hospital Association felt that there is a potential for 500,000 deaths by the end of this year so far as coronavirus is concerned. The facts speak for themselves. We are now in the midst of a pandemic. Now let's look at India. India is in stage 2, where we are just starting to identify local transmission from positive cases. Eventually, the disease may reach stage 3, where it spreads in the community and large areas can get affected. We are all familiar with the necessity for quarantine, contact tracing, and to stop mass gathering, creating awareness, preparation, and so on. The World Health Organization Director General has repeatedly stressed test, test, test. Easier said than done. The picture in the middle shows how literally thousands of people can assemble around a testing center, and this by itself certainly increases the risk of dissemination of the coronavirus. Who is at risk of infection? Every single person apparently is ultimately at the risk of infection. Now let's see what exactly happens. Physician, heal thyself. In all countries of the world, we depend on the healthcare system. The healthcare system everywhere is challenged. I remember when I was a medical student almost half a century ago, these were the wards, this was exactly the type of wards where I studied even as a postgraduate student. Today, there is a very real possibility that this may come back. What happens when the healthcare provider becomes sick? Who is going to look after these patients? And more important, is there not some way using technology where we can reduce this? The health of the healthcare workers during a pandemic is absolutely critical. Increased attention must be paid to the health of the healthcare providers. Just a few days ago, in one of the leading national institutes in Thiruvananthapuram in Kerala, 78 doctors had to be quarantined because one of the doctors proved to be coronavirus positive. The Center for Disease Control and the World Health Organization have strongly recommended using telemedicine to direct patients to the right site of care during the outbreak. Now, I'm just showing you a few photographs taken from the world media. It is amazing that telemedicine, suddenly everybody seems to be aware of it. China embraces telemedicine. Most of the TV channels in the United States talk about telemedicine. Hong Kong is using telemedicine. Singapore is using telemedicine. Let our technology do the traveling instead of our physically traveling. Before I go into the specifics, let's spend a minute on what exactly is meant by telemedicine. Telemedicine has made geography history. Today, distance has become meaningless. Telemedicine is the delivery of healthcare services where distance is a critical factor, we obviously require hardware, software, connectivity. The various aspects involved are acquisition of an image, storage, retrieval. Of course, orientation, training, customization, all these are required. And I would like to spend a few minutes on how this is important specifically for the management of COVID-19. Before I go into what I think could be done in India, let's spend a few minutes on how telehealth has been employed specifically for the management of the coronavirus. Let's take China to start with. Chinese telemedicine services such as Ali Health, part of the giant mega conglomerate Alibaba, quickly launched online coronavirus clinics to triage and treat patients. JD Health, one of the major telemedicine companies in the Republic of China, is conducting 2 million online consultations per month, an increase of tenfold after the outbreak of the virus. Again, several major hospitals in China are using telemedicine as part of their system. The Prime Minister of Australia has notified on 11th March that new telehealth consultations will be covered under the Medicare benefit scheme. Those isolated due to the virus can access medical services from home by audio or video. Funds have been devoted exclusively to telehealth. This is happening in many other places. This is an extension of telemedicine, if you want to call it. In Singapore, at the Changi airport, health officers are screening arriving passengers with thermal scanners, and any positive cases immediately, electronically, the information is sent to a telemedicine consultant located many, many miles away. A robot moving around the healthcare facilities, spreading ultraviolet light to disinfect rooms, or a disinfectant spraying robot, all these also are an extended arm of telemedicine as such. The United States very recently introduced a bill which is valid till September 30th called the Coronavirus Preparedness and Response Supplemental Appropriations Act. Out of $8 billion exclusively devoted to the management of the viral infection, no less an amount than $500 million have been specifically allocated to telehealth. When the United States can do this, why can't other countries follow suit? The health insurance providers in the US have responded beautifully. Almost every single health insurance company, whether it be Medicare, Medicaid, whatever it is, United Health and so on, they have all said that they would reimburse telemedicine consultations. This slide gives a list of various companies which have now made video visits much more common than a face-to-face visit. As you can see in the fourth panel, everybody has waived the co-pay share in teleconsultations and is providing access to telehealth services at no cost. Drive-through testing stations are now being established in Colorado, Connecticut, Washington, and other places. The results will directly be communicated from the cloud to the person who's using this. In other words, remote healthcare and technology is the name of the game. Now let's look at India. What do I have in mind? What I think, we are all people living in India are familiar with the ASHA, accredited social health activist, or the basic health worker. We have tens of thousands of these people, all IT savvy, all having a tablet along with them. Tele-answers can be filled on a tablet, instantaneously stored in the cloud. Real-time big data analytics will help update policies. For a country where every sixth human on the planet lives, 1,300 million people, the technology, and only technology can help us even collect data. And we know for epidemiological studies, we need real-time data. If video conferencing facilities are available on the patient phone, and I understand from a recent report of TRI that almost 30% of the million mobile phones in India are smartphones, and many of the others also can have a crude video conferencing facility. So if this is available, the patient can even be examined from a distance through video conferencing. If the algorithm warrants, the first remote screening can be escalated to a video consult with a specially trained nurse or even a doctor. Telescreening will clinically identify those requiring laboratory tests. Hundreds of thousands of individuals need not physically go to testing centers. In other words, by clinical evaluation, we should be able to reduce and we should be able to identify what today is called the coronavirus-like syndrome. Time-specific appointments can be scheduled in the nearest lab. This will again reduce the crowding at the level of the OP, at the ER, and even a doctor. Since all the records are already available in an electronic medical record, the patient can come within a few minutes when the appointment is given. Hundreds of people could be screened, ensuring that at any given hour, not more than 10, 20, 30 people are there. The results of the lab test can be communicated electronically and symptomatic treatment initiated using an e-prescription. Now let's look at the specific advantages of deploying telehealth. Managing coronavirus infection is essentially keeping sick people out of hospitals. Unlike what is conventionally believed, we do not want people to come to hospitals. Telemedicine, ladies and gentlemen, can be a safety valve for a strained healthcare system. Virtual visits can be a very effective way to decide who needs to be tested for COVID-19. Telehealth provides remote consultations for normal health issues. We are concentrating so much on this viral infection, we forget that by quarantining millions of people, we are denying or making it very difficult for those who are self-quarantine, hospital quarantine, whatever form of isolation it is. Nothing prevents him from getting an acute appendicitis. Nothing prevents him from getting a convulsion, from developing severe headache, back pain, etc., etc. So this is one place where telemedicine can really come to treat non-COVID-19 conditions during the period of isolation. Automated screening algorithms with local epidemiologic information can be used to standardize screening and practice patterns across the providers. OP practice is impossible to keep up with rapidly evolving and changing recommendations for a new disease, a disease which we still do not know the exact causative factors, the etiology, the pathology, and so on. So electronic dependence is absolutely essential. Health systems have already developed automated logic flows. Chatbots are now available for most of the tertiary care hospitals in India. This can do the initial screening and then decide whether the visit should be escalated from a chatbot to a trained nurse or to a doctor. It is critical that COVID-19 suspected patients are not, I repeat, not routinely referred to casualties or OP services. This will considerably minimize the risk of exposure to other patients and, more important, the risk to healthcare providers. A single remote clinician can also cover multiple sites spread over different geographies through teleconsultation. Almost every country has a shortage of healthcare providers. If healthcare providers themselves need to be quarantined, it would lead to a disastrous situation. Infected individuals with minor symptoms can be managed at home with simple measures and monitored frequently through telemedicine. This will significantly reduce the spread of virus in the community. We will always have a group who are very worried. These worried individuals can also be monitored virtually with reduced risk to the community. Theoretically or even practically, respiratory clinics, mobile clinics, manned by trained paramedical staff can be set up in remote locations. Doctors and specialists can do virtual teleconsults in these mobile clinics, which can even move from place to place on different days. Early identification can lead to isolation and, if required, hospitalization. Health education regarding the epidemic can be done through videos and animations in local language, and these videos can be delivered to the mobile phones. And this can also increase the awareness. Telehealth could be a crucial component of India's national strategy to build capacity to combat the virus while keeping healthcare facilities safe. Telehealth alone can be an effective alternative to in-person visits for patients with other healthcare needs. All the stakeholders in the ecosystem, whether it be the central government, the state government, private hospitals, insurance companies, laboratories, and most important, the individual beneficiary, everyone plays a vital role in realizing the potential of telehealth. What are the challenges in introducing telemedicine? It is easy to talk and say telehealth should be there everywhere. A rapidly expanding use of telehealth is a challenge for providers who at the moment do not have a telehealth program. It takes time to establish the necessary technology infrastructure, recruit virtual providers, provide training on best practices, educate patients about telehealth through patient-facing websites, social media, and direct outreach. One, unfortunately, has to negotiate coverage with the payers. It could be a public-private partnership with state governments. One needs to persuade insurance companies to reimburse teleconsults or facilitate direct easy digital payment by patients for professional services rendered. Resources need to be mobilized to build infrastructure and capacity. To encourage patient uptake of health options, providers should proactively and frequently provide information on how to use the technology to access care. Remote clinical examination of a suspected coronavirus patient is eminently doable. A reasonable, adequate clinical examination can be done remotely so long as I have dependable bandwidth and a good, inexpensive video software. Fever, cough, shortness of breath can all be evaluated remotely. Video of a well-illuminated throat and nose can be seen on a screen remotely of a suspected contact. Digital stethoscopes are freely available in the market. These can transmit lung and heart sounds. It can amplify heart sounds 40 times and work with 7 amplification levels. The transmitted audio file can even have a description of the sounds with a provisional diagnosis which the clinician at the other end can confirm. Blood pressure, pulse rate, respiratory rate, oxygen saturation, and temperature, every one of this can be monitored remotely. We have been doing this for the last 2 decades. A layperson can perform basic examination and send the data to healthcare providers for detailed analysis. These are just some photographs taken showing a thermometer connected to a mobile phone and how you can look into the interior of the throat. So many devices are available which can help one peer into the throat, into the ear, into the nose, and so on. Small Bluetooth enabled stethoscopes, pulse oximeters, pocket-shaped L12 lead ECGs, pocket ultrasounds, high-dense webcam, all these are commercially available. So ladies and gentlemen, what is the way forward? No telemedicine program can be created overnight, but then a beginning has to be made. Now, not today, but yesterday, before it is too late. Like the All India Institute of Medical Science and the IITs, active existing telehealth systems can mentor and handhold new telemedicine systems which need to become operational on a war footing. If we can create a new medical college every fortnight during the last couple of years, certainly 10 telehealth departments can be created every day if there is a will to do it. 425 medical colleges, 650 district hospitals, and at least 1,000 secondary, tertiary hospitals in the private sector should have basic operational, functional telehealth units within the next 100 days. It is doable if the determination is there. Digital health is bringing out a revolution, shifting the point of care to where it should always have been all the time. The patient's abode, not the hospital. The hospital of the future is the patient's house, not ICU units. Awareness must be raised among patients about the benefits of telehealth. Technology acceptance as a behavior modification strategy should be considered. Even in the USA, 88% of companies with 500 or more employees offer telemedicine as part of their health benefits. However, only 9% of eligible employees used it. This mindset has to be changed. The problem is not technology, the problem is our willingness to accept virtual treatment. The Apollo telehealth system today provides almost 5,000 teleconsults a day, mostly for primary and secondary care in a public-private partnership. With a little tweaking, all the existing telehealth systems in the country can have an additional dedicated virtual COVID-19 telescreening program. Winston Churchill said, I quote, "Never let a good crisis go to waste." There are known knowns, there are unknown unknowns. Today, telehealth unfortunately comes in the last category, and I think very soon it is imperative that telehealth becomes a known known and be used in the management of this pandemic if we are going to prevent further problems from occurring. Thank you once again. Let us beat this virus together. Let us remember we can do it virtually, not necessarily face to face.